Okay, are you ready? I'd like to call the workshop between the Petersburg Assembly and the Petersburg Medical Center Hospital Board to order if I could. And with that, I think since we have enough new names around here, we'll just go around and introduce ourselves. Tonight, we'll be missing one assembly member here. Bob Martin's at a SARA meeting for the next couple of days in Ketchikan. Jay Stanton Gregor will be here. There was an emergency occurred. He'll be here in about a half an hour, I think. Anyway, with that, I'll turn that over and go over here to my colleague on my left here. If you want to introduce yourself and talk about.
Rob Schwartz, Assembly member.
Yeah.
Scott Newman, Assembly member.
Go back, Johnny. Thank you.
Joe Stratman, Hospital Board.
Jim Roberts, Hospital Board.
Eric Cook, Hospital Board.
Cindy Logadakis, Hospital Board.
Marlene Cushing, Hospital Board.
Thank you. Come around to Phil.
Yeah, Phil Hofstadter, CEO of PMC.
Steve Giesbrecht, Borough Manager.
Jeff Mucci, Borough Assembly member.
James Valentine, Assembly member.
Thank you. With that, I'm going to try to move it along tonight and see if I can keep it to about an hour, 15 minutes or so. With that, Jared, are you going to head it up for the hospital board or do I turn it over to Phil?
Go ahead with Phil.
Okay. Phil, you've got the floor.
Thank you. Thank you all again. This is, I think this is my 8th or 9th one here. So how far we've come from the hospital side. And that's what we're here to talk a little bit about. I don't want to take up too much time, but on some of the operational stuff, but I feel like we need to go over, let me just get the PowerPoint up if everyone can look at the screen okay. Here's the agenda. And so I'll spend a little time just talking over the operations, some of the key milestones, strategic initiatives, strategic plan that we have covered. Jason is online, our CFO, and he's going to cover some of the financial performance from the past year as well, at least from the past fiscal year. And a replacement facility development, I think we'll probably spend the most time on, if that's where we have our owner's rep here, Arcadis, and our architect from Bettesworth North is here. And they'll provide some update on where we are with the existing work building, sort of a view from the past year on the work building, and also what is sort of the strategy and concept from going forward, which we've talked a little bit about, but it's good opportunity to talk in more in depth on those. And then there's a bullet here from Mayor Lynn regarding the housing work session. And then last is I'll have Katie Bryson, our strategy and grants manager. She'll talk about the Alaska Rural Healthcare Transformation Program. We probably want to reserve enough time to talk through that because it's so new and there's a lot of information around that. What does it mean? What are sort of the rules behind it, and how does that funding work from the healthcare initiative or healthcare transformation standpoint? If that's okay, I can proceed.
Go.
Here's our wonderful hospital board. Get some over here into the assembly chambers. And just a little bit, we do a mission, vision, and values. I always have a slide on this. But really, when we look at the initiative and the organization in healthcare, we always want to have the mission, vision, and values under the umbrella of quality. And we focused a lot on quality in our initiatives, from governance down to our managers, down to our staff. So across the whole organization, we want to make sure we capture quality in our mission, which is excellence in healthcare services and the promotion of wellness in our community. The vision is Petersburg Medical Center will remain committed to excellence in healthcare, responsive to community needs by being the best place for patients to receive care, employees to work, and physicians to practice medicine. Our values are professionalism, dignity, integrity, teamwork, and quality. All right, and our strategic plan hasn't changed just on the and the elements of it. We've changed the language a little bit. We've added things like community engagement, where we really wanted to engage the community in aspects, and financial wellness, where we really wanted to be healthy from a standpoint of finances. Not any one of those is the number one priority. They all work together, and they all need to work together. We can't do anything related to patient care unless we're not financially well. We can't do anything if we don't have good community engagement, workforce wellness, patient-centered care, and infrastructure to operate out of. So those are some of the elements there. I thought this slide was interesting. I presented this at our manager work session this year, where this was the 2018-2023 when it first came on. We identified some of the initiatives that we wanted to see that in that time frame. And it was interesting because we're actually operating and doing those things. Some of those are coming to fruition as we speak. So just an element of new service lines, expanding procedures, low-risk outpatient surgery and MRI. And we are, going live with our MRI in Petersburg here shortly, hopefully if the state approves it. Ancillary services line, service line expansion. And so we've expanded a lot of services, which I'll touch on in a later slide. Integrating mental health into primary care, into our services. We've done that pretty successfully. Still a lot to go as far as in growth, but we've spent a lot of time and with our grants and investment in staff and growing that department. And then, of course, the expansion of technology and telehealth to deliver healthcare services, which are all kind of wrapped up in a lot of those services, but also in our electronic health record, which we went live with a new one in 2022. I'm not going to go over each one of these, but under our workforce wellness, there's a lot of things that we do for staff. We engage our staff. These are some of the activities that we do on a monthly basis, where we try to activate and engage our staff. Everything from employee recognitions to providing chart notes. If Cindy's around, she does those on a HR on a monthly basis. Really popular with our staff. We also do forums, which are our all-staff meetings. I do a monthly coffee hours with the CEO. We do new hire orientation, educational opportunities, et cetera, et cetera. So we do a lot of things to engage and increase the morale of our staff. A few things from the statewide. This is actually just published every year. If you remember, those of you who were here last year, this was the workforce. If you look over to me here directly, I'm waving the magazine here. It's called Alaska Healthcare Workforce Analysis. We had our wonderful Petersburg employees on the cover and throughout this pamphlet. And this is put on each year. The latest one just came out, and a lot of the data stayed the same. It's still number one in the economic sector. In Alaska, with $3.7 billion in wages, 46,000 jobs. It comprises 13% of all workforce earnings in 2024. You can see that's higher than pretty much all the other industries in Alaska. So it's a very strong force as an economic. It's not just a healthcare entity, but it's a healthcare economic force. And that's at a statewide level. Also, if you had national level, you would see the same trends. And then also in our community, we see that. So we have approximately 13.8 million annual payroll, and that goes directly back into the community. So that's our full-time staff. That's not contractors. That's that's direct wages that go back into our community. There's a multiplier effect that's calculated also taken from the workforce analysis, about 1.5 for healthcare, and that multiplier is sort of the indirect cost of having somebody a family living in the community that has kids, and you have sort of this indirect capture of economic growth as a result of that. And so if you factor that in, it's roughly around 21, almost 21 million in total community economic activity to Petersburg as a result of the hospital. Here's a slide from our human resources Cindy had put together, and it looks at our growth in our staffing. And so roughly we have 135 full-time staff. That number is flux. We've increased that over the years. Where we've seen the largest growth is our seasonal, our intern program with our high school students, and also our youth programs. And another area that we've grown is in the billing and accounting, the billing office, when we took in-house our billing function. So those are sort of the areas of growth that we've seen. And you can see our youngest employee is 15 years old, and the oldest employee in 74. Both shall remain nameless, of course. A slide on turnover. I thought this was very interesting. The red is Alaska state, or sort of the overall turnover of healthcare staff. And roughly, you could see coming out of the pandemic is pretty high. And, 28%, some a couple of years, 23%, pretty steady at 23%. Petersburg also had pretty high turnover coming out of COVID. And then it's gone down over the years. In this past year, as you can see a really low percentage of 7%. So those are really good numbers. This slide, it's fairly complicated, but it's came from the Alaska Hospital and Healthcare Association. It's our statewide agency. And this slide really depicts sort of the challenges in healthcare. And we see this also here locally. They call it gridlock. And it's really about having patients that not really appropriate to have a high medical need in a facility, but there's nowhere to go. There's no place to have somebody in a facility if they have, if they have dementia and they don't have a safe place to stay at home. There's no payer that will pay for that. And so they end up getting stuck in the system. This is very common, unfortunately, in our health system. And there's a lot of healthcare dollars. It's called uncompensated care in our world. And we experience this as well. They're unsafe to discharge. There's no place for those people to go because there's no facility that really takes care of that level of care. And AHAD, which is our hospital association, did a really good job of analyzing that and talking about how much the cost is and the cost burden of that. And it really speaks to the infrastructure and the facility of healthcare in Alaska and the importance of having infrastructure in our facility, update and modern facility locally. So, and I could do a deeper dive on that later. But, and this is just a slide. Our staff went to the career fair at the school this past year, just sort of that engagement, workforce wellness. And this is, we have our patient-centered care. I call it the continuum of care. You see a lot of our focus in our patient care is not just in the facility, in the building. We spent a lot of time building out our home health program. We have an adult day program as well. We expanded our services outside the facility. I'd even call our youth wellness part of our continuity of care or continuum of care model. And those are some areas that we really want to grow and be partners in the community. It's just a snapshot of our primary care clinic. A few things to note. We spent a large focus on reducing wait times and access for specialty appointments. We obviously have our Saturday clinic, try to meet those needs as well. And then our same-day urgent care appointments where we make those available. Those are the same day and those are immediate. And obviously those reduce the cost of our ER. And then the technology upgrade, as I mentioned previously, we have sort of the most modern system and including telehealth services and beyond. We had a fully staffed clinic. We did have a fully staffed medical staff, but unfortunately, Dr. Morgan has left, so we are down one physician. We're recruiting for that, but otherwise, pretty fully staffed. Our preventative services are noted there as well. One thing I kind of want to mention, and again, I don't want to spend too much time on this, but there's a service we'll be providing in the not too distant future. The state of Alaska passed a bill a couple of years ago that allowed healthcare facilities to do direct primary care contracts with patients in the community directly, where you can bypass the insurance payer system. You could have sort of a subscription model and get your preventative care, talk to your doctor, some basic labs, and we'll be rolling that out as well. It's a way of trying to make healthcare more affordable, increase our utilization within the community, and also making sure that people get their prevention visits to offset those high-cost dollars and if people end up in the ER. So we're trying to make things more affordable for the community, especially in this climate where healthcare is taking a lot of oxygen out of the room, when the costs are really high. And this is a slide on our specialty service lines that we've grown. We've brought in, we do audiology, which I do, optometry. Dr. Kapp is actually here this week, recurring. She's been great. Dermatology, endocrinology, we had Dr. Harrison over from Wrangell recently, and that's a service hopefully will continue. We have Dr. Rasser in ENT, psychiatry, Dr. Sonkus. He's mostly telehealth. He does come on site periodically and provide in person. Dr. Heyer's been doing telehealth integrative medicine, and of course, we're doing the MRI. So there's just an example of some of the service lines we've expanded, and we are very excited also to bring back scope clinics. Our next clinic is coming up on the 5th and 6th, right? Is that right? Getting nodding heads, yeah. So some exciting things on that line. Sort of unknown a little bit, just to give a few data points on our clinical behavioral health services, we've expanded that program. We have 2 licensed clinical social workers, Ashley Kawashima and Pat Sessa. Pat is remote. Ashley's local. She works in the school a large part. We also have Abby Hardy as our behavioral health associate. She does a lot of telehealth visits as well and facilitation there. And then our psychiatrist. And a lot of these are grant funds. We've slowly built this amount, and we've just have some numbers there on our services. We provide behavioral health services for PMC staff courtesy, free of charge, basically. We have 2 programs, not just our clinicians, but our BetterHelp is a contractor where we provide those kinds of services as access to behavioral health within our staff. And then we capture our wait times, so just a sort of a snapshot there. It's our home health program in Al Delta, just sort of some good imaging there on our program. Excellent work there. This is something you'll see when I looked at the statewide report. This is probably the line of growth that's going to be the most, I think, in the next couple of years. I hear a lot of conversation from the RHTP funds coming on home-based care. Home health is a Medicare program. Adult Day is a waiver Medicaid program. And then home-based care is something that's more on the prevention side. So those are kind of 3 different aspects that all bundle under home health, but they're different regulatory requirements under each of those. We've also launched a telestroke program with Harborview, and it's taken a little bit to get online, but it's pretty incredible that have the access to experts and neurologists there, and it's been successful so far, and so we're excited about bringing that to Petersburg Medical Center. These are just the activities on the community engagement and different things that we do. Again, I don't have to go through all of those. Youth programs is a tremendous success and expansion in our programs. I don't have the exact numbers on those, but the Orchid camps, the summer camps, the growth in youth programs is pretty incredible. All right, this was a fun slide to put together. When I said financial performance and the arrow goes down, why is that positive? And I did put a green on there. And that's our AR, our accounts receivable. And that's where we focused on getting our claims out the door. And if you hear in the news, for example, where you get denials and insurance and payers denying, this is accounts receivable are the metric for that. The higher number of days, the less likelihood you'll again recouping bills and claims. And so keeping those down has been a huge project of the organization, and really want to commend our staff for bringing that down into to standards and national standards. So that's been an excellent project. And with that, I will turn it over to Jason to jump in on financials. Any questions on
Thank
me
you.
before we sort of jump on either side? That was quick, I know, but I know we're running short on time.
Good.
Yeah,
Okay,
already.
Jason.
Excellent. So I presume everybody can hear me. So let's move on to the first slide. So rural hospital finance, I just wanted to take a moment and talk about how operating a critical access hospital, that's the designation we have from Medicare, and how that is unique for us versus most traditional businesses. So, when we look at a traditional business, maybe we're going to use the example of fishing here. You have some equipment, maybe some software, some things, and you go out and you try to, the market determines what you sell your product for, and whether you're profitable or not comes down to how many fish you catch, how many services that you provide. And once you reach that break-even point, then you're successful. Well, we work in a very strange environment in healthcare. It's related to the government, and so it works opposite of what most people would think. So next slide. So for Medicare, we are a critical access hospital, so we are reimbursed on costs. And the same is true. It's administered in a slightly different way, but we are reimbursed based on costs from Medicaid as well. And that can be upwards of 70% of our business. And so in this situation, we're not reimbursed on what we charge. We're reimbursed on our costs to run the organization. So the quick example here is let's say that the cost to run the organization for the full year is $24 million, and 50% of our patients were Medicare patients. Well, then Medicare commits to paying us $12 million. We send statements, send claims out as patients receive services, and they pay us. But at the end of the year, we submit this great big thing. It's kind of like a tax return, but it's called a cost report. And if they've overpaid us, we pay them back. If they've underpaid us, at the end of the day, we're going to get costs, not cost per patient, but cost to run the hospital based upon the percentage that Medicare provides. It's kind of odd. How do you ever produce a profit then if you're always reimbursed by cost? But we'll get into that. But let's go on to the next slide. So in our situation, about 70% of our patients between Medicare and Medicaid, especially with the nursing home, were reimbursed based on our costs. And as I indicated previously, that includes depreciation. Depreciation is where you take the cost of something, a piece of equipment or a building, and you allocate a piece of it each year, even though you may have already paid for it, or you borrowed money to pay for it, you expense it as depreciation. So let's use this example. Let's say, that it costs us $100 million to build a new hospital campus. Well, annually, that turns into a depreciation of $3,571,000. We have some additional staff to be able to operate in that situation. So the amount paid by Medicare and Medicaid will be, 1.4 million of that. So if the building is paid for by a grant, that's the situation that we have with the first building, we still depreciate that building, and we still get paid cost on that building, even though we didn't pay for that cost. Kind of a strange situation, right? But that's the way reimbursements work in rural healthcare. And so we are anxious. We want to be able to build this new hospital campus as much as possible with grant funds, because it will provide us with this additional compensation as we depreciate the building over the next 30 years and help us be financially viable. Let me pause there and see if you have any questions. I know it's a big ask. We've talked about this for several years now. How are we going to be able to operate a brand new campus with all the additional expense? And that's why I wanted to go over this, is to help people realize that because we built a new building and we're able to depreciate that building, we will receive additional funds beyond. We're leveraging the funds that were given to us as a grant to build a building, but we also still get reimbursed for the building. And it helps us to be viable for the next 30, 40 years. You have questions?
Don't see any, Jason. Go
Okay.
ahead.
On to the next slide. It's important not to delay. So we're anxious to build the next phase. Construction costs have been going up quite quickly, especially, post-COVID. I think they're a little calmer right now. With the high interest rates, construction is a little slower, and so it's preventing those costs from going up. But when we see fuel and labor costs and inflation, things of that nature, once you decide to do a project, it's better to move forward and to get it done. And so we're anxious to come up with that set of funding to be able to do the next stage of this project. So another reason we have a lot of patient care that we need to provide is the baby boomers age and cost more to the Medicare program. Then the feds start sunsetting some of those programs, and we want to make sure that we get in before they shut them off to be able to pay for this construction. We also want to make sure that we have a nice building to accommodate increased patient care. I think there's some statistics we might not have gone over in detail, but our nursing home is busting at the seams. This past year, we've been at capacity, and being able to get into a new building and be able nursing home and have some additional beds is going to be important because, if we're full right now and we've been caring for what we call the Great Depression era generation, as we move into the next 2 decades and are caring for the baby boomers, there's a lot more care to be provided. And so we do need to plan for additional capacity. Next slide. Let's see. People judge a hospital by its building, just like they judge a book by its cover. And so having a new building will help us decrease outmigration. That's when patients travel outside of the community to get care. Current building's over 40 years old. And so Medicare pays the cost. If the building is fully depreciated, then there's no cost report. So before we built the work building, our reimbursements were really low. We kind of struggled a little bit financially because we didn't have that additional depreciation cost. Building was fully depreciated. Next slide. And then the 5-year financial performance. So just wanted to provide a quick slide here to see some of our growth as we're coming out of COVID. In fiscal year 2021 to the present, you can see that our total operating revenues have grown from 24 million to 28 million. Just really love working with PMC, with the whole team there, with Phil. What a vision, what an incredible ability to connect with the community, identify healthcare needs, and find a way to solve them, even if it's like Kinderskog and it's dealing with our children in education or just whatever it is. We're finding needs and we're meeting them, and that's what our mission is. Total operating expenses have grown also from 21 million to 29 million. Not a bad thing because, as we say, we're reimbursed based on cost. Our operating income is a little bit, misunderstood. As an organization, we're required to report what's called an OPEB transaction. It's our retirement through the state retirement system, and the actuarial reports, and it distorts our operating bottom line. So it shows that we reported a loss here in fiscal year 2025, which we actually did not. If you back out that journal entry, which is a couple $1 million, shows as an expense under our benefits, personnel expense. That's why it jumped up a couple $1 million. You can see there. Has to deal with just actuarial reports. We didn't actually cut a check for that. So we were profitable last year. And then you can see with the grant funds that we received to build the building, we recorded 8.4 2024 and 15 million in 2025. Just very grateful that we were able to find that grant to build 2 grants to create the design and build the building for the work building. Then our net position, you can see basically the net change in net position is basically our bottom line for the year. Next slide, if there is one.
That's it.
Okay. I just wanted to, in conclusion, just, the purpose of some of that slide is just to help the borough, help the board, help the community understand how this change helps us be financially viable for many years to come and to meet the needs of our community. And we just also wanted to show that as we've come out of COVID over the last 5 years, that the hard work that has been done has moved us forward into a stronger financial position, both in terms of our income statement as well as our balance sheet. Our balance sheet shows our assets, shows our bank account, things of that nature. We have a sufficient amount of what we call days cash on hand, or savings account, if you will, to be able to weather any kind of storm that may come. They happen on occasion, but it's important to have something tucked away, and so we're in a good situation financially. So back to you, Phil.
Thank you, Jason.
Any other questions from the assembly or board? Move forward there, Phil, if I don't hear, oh, Cindy?
And the MRI and the work building. The opportunity is out right now to make comments regarding the MRI, and you can find that link on the PMC webpage, and it's also on Facebook. And we need those comments from the public. So just, there's an opportunity for you to.
Mr. Mayor, I'm going to jump in. Just a reminder to folks, speak into the mics, otherwise Becky won't get your comments.
Okay, Phil, go ahead.
So next up is Justin Wetzel from Arcadis. He's here in person.
Good afternoon, everyone. Justin Wetzel. I just wanted to start with kind of an update on the work building. Following the completion of the building itself, we were able to, during October, to extend the Wellness Drive road through to Excel Street. That was kind of an effort that we had planned for, pending a lot of the project costs were coming in where we were forecasting them to. And so in advance of that work, we went out and got the core permit for the additional ground disturbance. And that work was completed in October following the completion of the building itself. We are still working on a final submittal for ADEC on the future hospital site to close and stabilize that area. And we are currently, the contractors remobilized, Dawson's remobilized, and we also had Capitol Office in Petersburg. We installed at the entryway a monument sign and some additional interior signage. And we're making some upgrades to the facility in terms of electrical, UPS, uninterrupted power supply for the magnet, for the internet servers, and the vaccine fridges. So that's kind of what's kind of going on right now. Any questions on kind of the closeout of the work building before I move on to the next?
I don't see any here, so yes, please go ahead.
Okay. I wanted to just kind of run through a summary of the project itself and kind of capture some of the performance and success that we had on the project. As just kind of a historical background, the work building was an alternative contracting method. A CMGC, or construction manager general contractor, versus a fixed firm bid. It's basically allows for the contractor to engage in the project in sometimes a limited amount. Like, for example, we started the contract with Dawson and started the site work. We started to develop the design, which allowed us to kind of move those two things in parallel. With the short building season in Alaska, those are the kind of things that can, be advantageous to a job financially. Making sure that you're not putting the roof on in the middle of winter, those kind of things. So it's very important. And with this delivery method, it's a two-phase collaborative approach because we also brought the contractor on during design development. So that allows a lot of their input into the project when they're already on board. And so you get value engineering, you get the overall project approach is a collaborative effort versus just the owner and the design team telling the contractor, this is what you're going to do. Instead of it creates a team environment and creates a lot of efficiencies. So for the work building, we signed a contract with Dawson at 65% design development. So we hadn't reached a full design drawing. In a typical fixed firm bid, you would have had to develop 100% construction drawings. It would have gone out to bid and you could potentially miss the building season. So with this type of method, we were able to come up with a guaranteed maximum price for the work at 65% drawings. And while they were pouring concrete foundations, we were continuing to develop the design. So it's another method of kind of doing design and actual construction activity on site at the same time in parallel. So let's see. So with the early start of the construction, and the actual performance of the project based on the original timeline that was allotted, the project was delivered substantial completion in June, which was 2 months ahead of schedule from the original schedule that was developed. It also allowed for PMC to negotiate with Dawson for a guaranteed maximum price that was based on the funding constraints and other factors. But basically what that does is it allows flexibility for the actual execution of the project to eliminate change orders, because one of the risks that's involved in going with a 65% design contractor is when you get to 100% design development, there's changes, there's adjustments. And a lot of times in projects that ends up meaning change orders and additional cost to the project. So through the execution of the work, Dawson was able to recognize a cost savings through activities, the means and methods and efficiencies, and based on the high level of performance, those savings were reincorporated back into the project. So in a typical fixed firm bid, those costs, those would have gone to the contractor. And in this case, in this delivery method, it gets rolled back into the project. Basically, I wanted to go over the following construction activities that were originally not part of the project or deferred. Some of the items were on this list are items that we wanted to do but weren't guaranteed in the budget for that dollar amount. And all these items that I'm going to list off here were not in the original budget or scope, and they were reincorporated back into the project at no additional cost. Number one, the wellness drive and the work parking lot paved in reinforced concrete. That's basically valued at about $400,000. The wellness drive road extension to Excel, which we did towards the end of the project, that was an additional $350,000 in value. The north retaining wall at the service yard was an additional $300,000 in value. There's additional landscaping and fencing at $100,000 in value. Higher quality and more robust FF&E package was about $200,000 in value. And audio, video, conference, and additional electronics like what we're doing now with the UPS, another $150,000 in value. So altogether, in total, the additional scope of work that was added back into the project exceeded $1.5 million in value. And so in summary, this project using this delivery method is kind of a clear example of a a dramatic impact back into the project in both cost and schedule, and an above average performance result. Any questions on that? Yeah.
What'd you say?
No, go ahead.
Yeah, thank you. This is very fascinating. One of the things you talked about is being able to pour concrete while you're designing a building. How do you do that?
So through the design process, we kind of hit milestone development. After a concept, it moves into a 35% schematic design, which is basically a layout of the building, including electrical and mechanical. And by the time you get to 65% design drawings, elements and disciplines of those construction drawings can be essentially 100% without the entire building being complete. And in terms of the site work, and then also in terms of the actual footprint, it basically, if we know the footprint isn't going to change and the remaining development of the project is going to be on the interior build out, then you can reach a development stage where you know that you can pour that concrete or order the steel, for example, with structural steel. So that's how it's kind of done. And there is an element of risk involved in that. But as long as that's, understood and controlled within the contractor's GMP, then there's allowances there.
Great, thank you.
Go ahead, Phil.
Yeah, I was just going to echo I think it comes down to the team being able to deliver in rural Alaska, a project that's under budget and on time is pretty an anomaly. So, and it's a struggle because normally you run a low bid project and then you're managing a change request all the time. And when you remove that off the table and you have a good team that puts that together, you're able to make kind of decisions on the ground. I mean, a great example is when they're pulling out, they were blasting early on. There was a decision point at with the blasting, could you actually process the gravel on the site? And those are like decisions that you can make in real time or more in real time than if you had sort of every step of the way, you're limited by scope and you're limited by low bid. And then you have to run it up the chain constantly to be able to manage projects. So those things, there's many examples of that where you can move quickly, and it really was an asset in this case.
You go ahead if you want to.
Did you want me to go over the timeline?
Yeah, I have it up there.
Okay,
Yeah.
perfect. So I wanted to put together a timeline of, this is essentially a hypothetical timeline, and it's also kind of what I like to call as soon as possible. So, the remaining campus build out is funding dependent. And so what I wanted to display here was if money was not an object and we were to start as soon as possible, what does that look like for a construction trajectory? And so you can see here, based on our most recent concept, with the multi-phased buildings, if we were to put into effect the long-term care design and planning in 2026, that could be developed to where we could start construction in the spring of 2027. And then in parallel to that, in 2027, the design for the hospital building or phase 4 could be started for design drawings and planning. And you would have long-term care construction continuing into 2028, and long-term care complete by 2029. At that time, it would be a transition of completing the long-term care and starting the hospital. The hospital construction would go into 2030, and the entire campus could be complete by 2031. And so I just kind of wanted to display a what-if scenario timeline for building out the campus, and it's the best possible scenario. If we were to start on design in 2026, and get funding for the entire project, that is a possible scenario.
I have a question for you, Phil, is if in the design for the long-term care, to me, you're going to have to look at the main campus as part of that. You can't divorce it. You may not have the full plans, but you can't divorce the two because you have to know where the site is and how you're going to tie everything together. Am I off base, or where are you at?
So we earlier last year, our architect, Roy, is in the room too, came up with a concept. One of the challenges I had going to funders, at the legislative, and actually when we went up to Juneau and then also in DC is what's the next phase has historically been, the full amount is 67 million thereof, right, for the next part of the whole project. The next phase would be a shell and core, which is basically a building with a roof on it and some and that's it. And so to keep the inside dry. That's not, when I was talking about that at a funding level, that really just got a lot of like, what does that mean? What kind of phase is that? And so when we were talking about that, it's such a big chunk. It's a good question. How do you come up with the remaining and have a building just sitting there waiting for additional funding? So if you're going to look at it from a operational standpoint, I met with our staff, and what are some of the things that what actually could you do that has a enclosed building and have an operation, and that would be long-term care. It's also the greatest need, and it's also the greatest at risk in the community. When you're looking at that, the age of that building is in the 70-year lifespan, I think, 1950s. That's the oldest part of the building. And so you could actually operate from a staffing perspective, from a regulatory perspective, you can operate that as a next phase turnkey standalone. And then, and Roy's actually going to talk about how that you can make that happen from a design standpoint. So that chunks it out, I think, and it keeps the project moving forward without having such an enormous amount requested and asked for. And if you're able to build that out, we can also accrue, equity as we go, and you could potentially be in a better position to have funding for that last piece. So that's the concept we're here to discuss.
Thank you.
Yep.
Other questions before we move on? Okay. Go ahead there.
Yeah, that's everything I had.
Did you want to add the square footage? I don't know if you want to talk
yeah.
about that.
Okay, yeah.
It's the budget numbers up there.
Yeah,
but-
so you're going to see in this spreadsheet here, it kind of shows the existing facility in comparison to the original. In 2023, we had a 35% schematic design for an entire campus that would be built out at one time. And then the last column there is basically the new concept. And one of the unique design elements of that last column and our newest concept is the shell space. And the new configuration, it's very close to the original footprint, but in the new configuration, the way it's situated on the lot actually opens up some additional square footage for the overall building, and that wouldn't necessarily need to be built out, with the project itself. It could be turned into shell space. And of course, all of that would be funding dependent. If there was, a certain amount of money that was available, we could reduce some of the overall construction costs. If 10,000 square foot of space wasn't actually needed and you only needed 5,000, you could turn 5,000 of that into shell space, and it could be future tenant improvement type space where you're building out interior walls and doors and drywall and things like that. But the actual structure and the shell is there. And so it allows for expansion for future growth in those areas. other questions?
Go ahead.
Thank you.
Oh, no, we still got 40 minutes, right? Or,
Hey, guys, I'm Roy Roundtree with Bettesworth North. I wanted to mention that Les is, the contractor is here in our audience today, and he's, been a great team member. And also wanted to call out, Kate Incarnato, who's on the video today. She is responsible for much of the work that we've done under this phase, and I wanted to give a acknowledgement to her. I did, before the meeting, I passed out a condition report. This was a document that we came to Petersburg. We went back through the building, every nook and cranny. We talked to Wolf about, it was more like therapy, really, talking to Wolf about all the things that he had to fix that week. But it was a really good synopsis of, the current state of the building. And the reason we did that was the last condition report was done in 2015, 11 years ago. And at that time, they noted that there were many systems in the building that lacked replacement parts, and they recommended full replacement of many of the systems. Now, that was 11 years ago, right? So currently, we would term the building right now in a state of managed decay. We would call that because when things break, if you can't fix them, you just route around them, you pipe around them, or you wire around them, and you abandon in place. And because the systems are aging now to this point, nearly, as you mentioned, the original main hospital is 43 years old. The LTC is nearly 60 years old, and it's never had a renovation that did anything significant other than paint or carpet. And of course, we know that medical requirements have changed a lot in 60 years. And what's happened with these systems is that, Wolf has had to actually source some of his replacement parts on eBay because they're not made anymore anywhere. The manufacturers are out of business, and, this is the kind of stuff he's had to do to keep the lights and the power and the water turned on. There's a lot of, as I mentioned, patient safety and regulatory risks. There's a lot of regulatory things that have changed. It is grandfathered in. You couldn't build a new building like that and get a certificate. But they're not going to close Phil down, mostly because of how well he's maintained the building and his staff, who are just super dedicated and committed to providing the care. Structurally, the building, maybe you guys have already heard all this before, but the last structural report was 7 years ago. And there are some major issues with the seismic strength of the building. If you did, we had a little quake off of Sitka a couple weeks ago. It's like, wow, where'd that come from? If you had a seismic event, we don't know what would happen in that building. So there's functional inefficiencies. A lot of the rooms are so small, you can't get, patient lifts in to move patients. So sometimes you have injuries because one person can't lift that patient, and maybe they don't call, or maybe they don't, no one else is on staff, so they try it, and then you've got injuries that even impact it more. Life safety, there's an example of a life safety deal is during a power outage currently, there is no heat. There's only enough generator power to power the life safety, the O2 system, the emergency lights. So an extended power outage, they're going to be looking for places to put the residents of the LTC. There's no, I mean, you can give them down coats for a while, but, so those are the sorts of things that, that they've dealt with. And in this condition report, you're gonna see a lot of lines that say, you know, replace system in its entirety. When we had our electrical engineers, we had our mechanical engineers, you know, some of the younger guys didn't even know what they were looking at, quite honestly, because it was so old. It's like, what is this, a Model A Ford? Like, how do I, you know, how do yeah. So, I think the silver lining and the thing that I keep going back to is that the professional providers, you know, we walked through it again today. And the people that are working there are just super dedicated. And Phil mentioned the attrition, you know, the annual turnover rate. Those people are committed to care, and they, you know, they're committed to doing a great job, and they are making do in that building as best they can. But best case, we've got another 5 years before we could have a new building, right? So we're gonna do another 5 years for sure. But I think you all should, everyone in the room should ask themselves, is it okay if you lose the LTC? Because someday in the future, you're gonna have a system break in that building that is going to be too costly and too much trouble to repair. And at that point, you're gonna have to shut down the 24/7 part of that building. It's just a matter of time. So how do we get to a new, the one thing, Phil told me that he and Wolf talk every week. And after a rainstorm, they say, okay, is it your turn to change the buckets in the attic, or is it my turn to go up there?
No, it's
and
always Wolf's turn. Yeah,
empty
it's
the-
not, it's usually a discussion of changing the
Yeah.
buckets, but
Yeah, you know, and that's just part of the system. And unfortunately, you know, if you take all your time in maintenance, repairing and being a fireman about what broke this week and what broke, you can't do preventative maintenance. And what really needs to happen in healthcare facilities is you need to have time to change the filters, change the air systems, do the system checks, make sure everything continues. But when you're spending all your time, you know, there's a whole bunch of pictures in that back of that report that I've never seen a cast iron pipe get worn out, like worn through. When you're spending all your time doing that kind of stuff, and then those resources that you're spending are taking away from the care that you could be providing, whether it be another staff person, whether it be, you know, a little bit more technology. It just, those resources cannot go to the right pot. So, as Phil mentioned, we came up with this idea to, you can advance that
Yep.
next slide.
Yeah.
Is could we do a long-term care facility as phase 3 with the notion that we were going to continue to do the entire hospital as the addition. And so the piece on the upper right is the first floor. The gray perimeter is the lower floor with the green of the long-term care. And there is sort of a diagonal division there that runs through between the blue and the light green. And that's the division between phase 3 LTC and then the entire hospital in phase 4. On the lower floor, the green in the middle is the PT department with some covered outdoor space adjacent to it. As we mentioned, that could be filled in later as PT grows, or it could continue to be, you know, outdoor covered therapy area. And then the gray part that loops around the back is the maintenance, the dietary, the new, what do I have on the other side?
Kitchen.
Well, support and maintenance, and then the dietary and laundry, excuse me, are also in there because we need those components to support the long-term care. And then the blue part is a small public area. We don't need it to be as big as the full hospital, but we do need something there. And then we've reconfigured the site over here so you can have a front door at the long-term care facility. It also has, if we go to the second floor, it also has an entrance on the upper level. As you remember, that's a 2-level design that we've always been going with. On the upper floor, we have an entrance for LTC that could be covered. And the nice thing about this new location for the long-term care is when we had it in the original design, part of the LTC overlooked the service yard. And so those residents were going to hear the beep, 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 beep every day with the trucks coming in and out. And Jennifer only told me 5 times to change that, and I'm happy to say that we finally did change that. With the LTC on the other end now, most of the LTC rooms have views out to the mountains, to the forest, and up to the thumb.
Oh, Devil's Thumb.
Yeah. So it's all on the second level, and it's starting to really be a home. If you could go back downstairs, the full hospital, phase 4, we've created a new drop-off for the main hospital, which is the little blue part down in the V. To the right of that, we have lab and imaging as the green, olive green. And then to the left of that, the red is all of the outpatient clinic space. So what's really nice about this new scheme is the clinics on the lower level, all of the clinic traffic can come in and out every day and not impact the acute care and things that are upstairs. And then imaging and lab are all there located on the ground level for a lot of the outpatient imaging stuff that has to happen. Phlebotomy and screening is all done down there. If you go back up, one other aspect of that first floor is that we do have the service yard, which is still shared with the work building. And that's where the main generator will go. That's where the main fuel tank, backup fuel tank will go. That's where the trucks will come in and deliver, supplies and such. And then the second floor, again, the upper level, we've worked in the ER entrance on the upper side with a covered ambulance portal. And the ER is on the upper side facing the forest. And then acute care is on the lower side again. We don't build over the entire first floor roof on this side. So acute care patients have the view out as well to the mountains. From a staffing standpoint, this really is really close to what they have now, where you have LTC, acute care. We have a lot of shared nursing staff that can go back and forth. The proximity of some acute care beds in proximity to LTC really makes Jason happy because now those are called swing beds. So we can bill for those under LTC at certain times as spillover. So this design that I put forward here, we've been talking very closely with the PMC staff, and we've also met with the steering committee at least 2 times to go over this. And what we'd like to do is push this design at least forward in design so that we can start to really get beyond colored squares and also so that we can get Les and his team with Dawson to give us some better newer pricing on what it's going to take. So that's a little bit better answer to your question about how do you pour concrete without the whole design. That's how you get architects really excited. And
I'm sure.
their blood pressure goes
I'm sure.
way up because they have to make sure they don't change anything after you do that. But I think in the case of the work building, you can save easily a year. And with escalation, at 3 to 5% per year, if you can shave off a year in the timeline, it's big money. So anyway, thank you. I'd entertain any questions you might have.
Questions for Roy?
I do.
Go ahead.
Every Roundtree is not a common name. So every Roundtree I've ever known, I refer to as Cuz.
Oh, Cuz?
Guy Roundtree was my great-great-grandfather.
Oh, yeah.
And Elsie Roundtree was my great-grandmother who became Elsie Clausen. So I'm trying to figure out how you fit into this whole
Fit in
thing.
now
We'll
you're
talk later.
Yeah.
But other than that, we're good.
All right.
Your Roundtree has a D in it.
Oh, that is true.
And so, yeah, the Juneau Roundtrees always wondered what the Petersburg Roundtrees were.
They wanted to I'll tell you what, they wanted to separate themselves from the rest of us.
Yeah.
Yeah, at some point, I think they did. Yeah.
Thank you, Roy. Okay, Phil, are you other?
Yeah, any other questions or anything? I mean, from the design or from the board standpoint or?
Do you want to take a 5-minute break? Let's do that then. Come back then in about 5 minutes. Yeah. Back to order, the workshop back to order if we could. And with that, Phil, are you done with that part of the presentation?
That part, yeah, we're, you wanna,
Okay. With that, let me move down then. I added an item to the work session here, and that's one of the issues that came up during the last assembly period we had for election was housing. And both the manager and I looked at that and said, housing's still an issue in Petersburg, even though we've done a significant amount. And so here recently, the staff and the assembly have got together and taken a look at what we've done and where we were going. We're kind of in the preliminary stages of what we're looking at. But with that, I'll turn that over to the manager, to Steve Gisbrek, and let him walk through it as we can fairly quickly.
What we're gonna do is with time being short, I'm gonna send our list that was put together by staff in the assembly. We'll send that off to the hospital and Phil will get it out among his group and we'll add to the list and I can answer any questions. I won't do it tonight, again, because of we want to make sure we get through this stuff, but I'll make sure the hospital gets a copy of what's been done so far and what we're thinking about.
Okay,
That works for you.
That would be great. And if the hospital board they would like to hold a different session, we certainly would, just to talk about those issues and where we might want to go. Okay, thanks, Steve. That'd be great. And with that, Phil, we'll work on to your the Alaska Rural Health Transformation Program.
all right, Katie, are you on?
I am. Let me see if my sound is okay. Can you guys hear me all right?
Yep.
Yes, excellent.
How about now?
We can hear you. You're good. Yeah.
I can hear you. So the sound went away as soon as I joined. Sorry about that. All right. Well, thanks very much. I know this is an area of a lot of interest and speculation, and Phil and I just went to meeting in Anchorage about this. So we all know at least a little bit about this subject, and unfortunately, there's still a lot of things that no one quite understands everything about yet. So I'm going to try and move quickly and not take too much of your time today, but also cover the bases of what we do know. And then I look forward to answering any questions that you have about things I go by too quickly. Excuse me. Sorry, I was drinking tea right as you transition topics. Sheena or whoever's advancing slides, if you don't mind going to the next slide. Thank you. So I want to start with the two things that we absolutely know for sure. One is that the Centers for Medicare and Medicaid have awarded Alaska the second largest RHTP funding allotment in the nation for the first year of the Rural Health Transformation Project funding. That's over $272 million, and that all has to be obligated by October 2026. And number two, we here in Alaska are very lucky. We've got a team at the Department of Health that has been working at a high level, very committed to collaboration with providers to make sure we have the best possible shot at seeing some true lasting benefits from this, and not just a lot of urgent chaotic spending, which I think we've all been around long enough to know that it could turn out like that if states aren't really on board with working together. Next slide, please. So these are the basics. The RHTP funding is not intended to be an ongoing federal program. It's a one-time allotment they've designed to be spent down extremely rapidly. The goal, as you can see, is to catalyze rural healthcare delivery transformation and improve access and health outcomes across the country. And next slide. More specifically, the state's proposal built on that overarching federal intention with this vision. I won't read the whole thing to you here, but it is in the slides, and we're going to keep talking about how that breaks down into 3 goals. Next slide, please. So those goals are to, first of all, promote lifelong health and well-being for rural, remote, and frontier Alaskans. And a bunch of different areas of care fall under that are relevant for us in our community. Second goal is to build sustainable outcomes-driven health systems, and they are specifically looking at pay for value there. And then the third goal is to drive workforce and technology innovations, and that's both strengthening our workforce, but also really investing in new tech. So that can look a lot of different ways. And then the state will basically be using the annual awards they get from CMS to fund statewide, regional, and provider level projects that support its aims and the outcomes they've committed to in their funding proposal. Next slide, please. So those outcomes are going to need to happen very quickly. As you can see, states will have 1 federal fiscal year to obligate all the funds they receive each year, although subgrants and contracts and their own direct spending, once obligated, can then be, as long as every dollar is obligated by the end of the federal fiscal year in October, we'll have then 1 additional year to actually spend everything down in full. But beginning in October 2027, any unspent funds will be taken back from the states by CMS and then redistributed among states according to some formula that they will have figured out by then. Next slide, please. So to make this many grants that quickly, the state is planning to contract with a grants administrator. This is widely rumored or expected to be the Alaska Community Foundation, either alone or in combination with another subcontractor. ACF has been supporting RHTP planning since last summer. They're part of the official advisory council. But it seems like until the state has an approved budget from CMS, they can't subcontract any funds. So officially, we don't know that. And what we do know is that it will be a massive undertaking. And while hopefully we're going to see the application process simplified by going through this third party instead of directly through the state, what is definitely going to be true is that there are going to be a lot of layers of reporting and compliance to satisfy all the state and federal requirements. And we also know since the virtual meeting that the state doesn't plan to support any indirect costs that subgrantees on this funding incur in operating the projects. So we'll all, not just PMC, but everyone who tries to support this project, this funding being spent in useful ways in Alaska, we will all need to be really thoughtful and judicious about the hidden costs that our organizations might run up against as we put proposals together. Next slide, please. A lot of people are going to be eligible to apply for project funding through RHTP. You might say everybody. And I will note, while they are not explicitly listed here, this is of course one of the state's slides from their presentations earlier in January. Not explicitly listed here, it definitely is included. Out-of-state entities are going to be eligible as long as they are working with a rural provider or can make a justified proposal. So that's just something to be aware of as we look at how these funds are being spent down and how partnerships are happening in the state. Next slide, please. So like I mentioned, state does not have an approved budget yet from CMS, although their award amount was released. So they can't officially subcontract their administrator. So we do not yet have either concrete guidance on the funding opportunities they're going to open first or a portal to submit our proposals into, but we do have a lot of very clear messaging from the state about how they're planning to bucket out these funds in the first year. Administrative plans and projects, administrative projects, planning projects, implementation projects, and then broader innovation projects. And that's things the Department of Health identifies both on their own and through ideas we can all submit and have been submitting since last summer. Next slide, please. So what can the money be spent on? A lot of things that we want and need and will work hard to get. But what it cannot be spent on is probably more interesting right now, especially for PMC's purposes. Specifically, there is no direct spending allowed on construction or acquisition of facilities or land. Renovation costs are allowed. I'm sure we're going to have more conversations about these restrictions, but I think the most important thing to know here is that Phil has been advocating really strongly all along since this legislation was first announced, directly with the Department of Health. And they're really working as good faith partners with providers who are in the same position as us all over the state to figure out, okay, well then, how can we use these funds to leverage other possible investments that do allow for us to spend on construction? So I am sure there will be more to come on that in the next month or so, because a lot of people are in the same boat, that it would be great if we're gonna, especially if we're gonna buy a lot of expensive new tech, it would be great to do it in a building that's not, as was just so eloquently put, in managed decay. Next slide, please. So this is what the state has shared so far about how they'll be evaluating proposals for projects. I think especially in year one, the emphasis is going to be on readiness, which you see there, and basically whether you are confident you can spend every last dime they give you in exactly the time allotted. And then also impact and whether you can help them move the needle on the very specific outcomes they've committed to with CMS. And then finally, the sustainability piece. We're all going to have to make a strong case that the impact of the projects we proposed under this funding will last beyond the grant funding. They have been very clear they're not looking to establish, staff positions that would need to keep on getting state funds to get paid for, as an example. They want to see a pathway to sustainability. Next slide, please. I won't read through this whole thing, obviously, but I wanted to make sure and include it here just because it really speaks to what the state is already thinking about in terms of the level of monitoring, evaluation, reporting, and compliance that we should anticipate on these funds. The grants themselves may be very short in their time frame, but the accountability commitment will not be. So it's something to think about again as folks are budgeting for any projects, and we definitely are looking at that. Next slide, please. Okay, so it is possible that the state will open a portal for grant submissions this week, as they hoped to do at the beginning of the month when they made these slides for their big convenings. More likely, we will see that open in February, and we will know more in February or whenever it opens about what exactly is going to be allowable and what they want to fund first and what specifically is required for proposals. But everyone can sign up for those updates and to learn about their future virtual and in-person meetings by following the QR code that's on the screen there. If you link to that with a smartphone. You can put your contact information in and you'll get the exact same email that Phil gets and I get and everyone else in the state gets, letting you know when, for instance, they're going to start getting regional feedback. All right, next slide, please. Okay, so how is PMC responding to this? Well, we've definitely hit the ground running. We put in one of the state's first submissions last summer in response to the Department of Health's RFI, and that was a very comprehensive list of legislation relevant, immediately actionable projects. Of course, our new facility was first among them, and that's part of the frustration in seeing how the legislation was interpreted at CMS. But, you know, we're all working hard to make sure some version of that will still be supported. We're already working to translate those projects that we outlined in the RFI into our first letters of inquiry. So that'll be based on the preliminary guidance that they provided at the convenings earlier this month. We just want to be ready to get those in as soon as possible after the portal opens. Not necessarily because we think they would all be funded, but because we're going to learn a lot more about their actual priorities and concerns when they start rejecting proposals too, you know, and accepting. We're definitely hoping for some acceptance. Next slide. And once we've got those submitted, we're going to pivot to an ongoing RHTP planning process that's very much more open, not focused just on those initial projects that we already had pretty much fleshed out last summer. We're working on an open sort of targeted project idea form that'll be related to the RHTP goals, and that can be open to personnel, partners, the community at large to put forward ideas, partnerships, collaborations. Obviously, proposals to this funding don't have to only go through PMC, but since we have an infrastructure to make those proposals, we want to make sure we're communicating with people over the next 5 years about what that looks like and what the best ongoing projects are going to look like for the community. Between March and October of next year, we're hopefully going to be implementing and monitoring and reporting on projects we get funded, and we will continue to submit additional projects throughout FY26 and into FY27. But really starting this fall, we'll just make it part of our annual practice for the length of this funding program to update our process based on the annual guidance updates and priority updates from the state and from CMS. Next slide, sorry. Yep, I guess there's going to be a lot more. I'm kind of skipping ahead a little bit because I feel like I've been talking at you forever, but there's going to be a lot more conversation to have about this funding and how PMC and all our partners in the region can collaborate in putting it to the best possible use for the community. I'm sorry, this is a very rapid fire foundation, general background. If people have more specific questions, I'm very happy to do my best to answer those now. And if you want to go to the next slide, if it's a better use of time during this meeting, you can also, of course, reach out to me directly. And I'm always happy to answer questions that way too. So thank you so much for taking the time to hear about this.
Katie, I think there's a couple questions here if you're ready for it.
I'm ready.
Okay. Go ahead, Member Valentine.
This is crazy, right? The way this spending, I mean, it just seems, yeah, it's not my favorite, but I know you guys are smart enough that I'm sure you're doing every workaround you can. But every question I wrote down, I basically had to scratch off as your presentation continued because you pretty much answered a lot of it. So just to try to, one thing that I can ask, because it sounds like it's a lot of just trying to get everybody up to a certain level. But like, is Alaska and are we behind in tech? Like, because it sounds like this is just a big tech grab to make us like a robot. Are we behind? Is Alaska behind in tech compared to other healthcare places?
Well, I'm sure there's better people in the room to answer that specific question than me. I think there's probably no better room in Alaska right now to answer that question than me, honestly. But I will say I share your initial response. We've had many conversations about how it is frustrating to see the live action creation of a camel by committee in process. You know, you see the legislation happen very last minute, and then you see CMS rush to, you know, figure out how they had a very short timeline to figure out how they were going to solicit funding requests from the states. All of the states, I personally think Alaska did one of the best jobs at immediately soliciting authentic, widespread communication and input. And then that was that was then channeled into one of the more complicated statewide grant proposals I've ever seen on a very short timeline. I think we all owe someone at state a cup of coffee for how much sleepless nights they must have had in the fall and over the holiday season, just pulling this proposal together. What I will say is any flaws that this program has, it can't be attributed to any one part of that process. It really is the whole continuum. I personally look at it and think none of this urgency is required. It's all manufactured, and it's too bad, because I think while getting things moving is not a problem and can often be beneficial, rushing into things rarely saves money. But it is the situation we have. And it's definitely my belief, and I know it's Phil's because he's more of a visionary and an optimist than I am. It's definitely my belief that a lot of good will come out of this for our state. And what we have to do is be really clear-eyed about what we're committing to when we ask for the funds. And that includes things we can't know yet, just like it did when a funding wave came out during COVID. It was not immediately apparent what the reporting and compliance requirements on that were going to be. We have to be aware of that. We have to get ready for it. And then we have to not be shy to take a risk and try to build something with this funding. And to, you know, luckily, like I said before, Phil is the ultimate advocate for building this facility. And every conversation we had, no matter how many people said, well, this isn't going to fund construction, Phil said, but how will it help us fund construction? And I'm going to be honest, I think they're going to find a way. And it's because of advocacy around the state.
That's a good question.
In terms of the tech.
What you just asked.
Yeah, no,
Yep.
believe me, I'm
I'll let,
Yeah.
go ahead, Phil. And then there's another question in for you, Katie. Go ahead, Phil.
I mean, and this again, this is just my opinion, but in the landscape of healthcare, one of the biggest challenges from a technological standpoint is not the technology itself as much as the interoperability. So like, for example, if we have one health system here at PMC, health record, I mean, like we have electronic health record here at PMC, it does not talk to Bartlett. It does not talk to Search. It interfaces maybe, but it does not talk to Harborview. I mean, these are really complicated kinds of situations. So at a patient level, if you're logging into your patient portal, you know, for your electronic secure health record, then you're not seeing whether you saw what you were seeing here or whether you were seeing wherever you went to college or wherever if say you got to an ER someplace in California, or you see your primary care doc in Palm Springs, you're not seeing that information. You have to specifically ask for it. It somehow gets to get pushed through. I still see fax machines. I still see copying in day to day, every single day. So to answer your question, 100% we're way behind the curve on it. And to me, I mean, the challenge for me is that I don't see, I'm concerned that we're not going to focus on interoperability as much as some tech solution, which is not the right way to necessarily do that. And then don't get me started on the claims side. You know, you have companies using technology to deny claims. You know, to me, I'd like to see a system that actually looks at the whole thing, where you have your plan, your health plan. James has his health plan. It's logged into that health system. You don't have to decide on what the copay is. You don't have to decide on what you owe in the back end. That's all seamless. And right now, that's all fragmented. So I mean, there's a large amount we need to do while retaining the safety and security of your records, which I think is something to be concerned about.
Okay, thank you.
Yeah.
Member Newman,
Asked the guy, they told me my days were numbered.
Yeah.
Member Newman.
So there's $272 million from the federal government for appropriating through people or hospitals, schools, et cetera, for this grant funding. And it, with the information I saw out there, it tells you everything that you can't do. And you kind of answered the question as you kept talking there about Phil being creative. My question was going to be, are there any ideas specifically like how we're going to propose this? But then you kind of answered it as you kept talking. It's like, well, tell me you want this grant proposal and money without telling me that you're going to build a hospital with it. So.
And, it's a great point. I don't want to overemphasize the things we can't do with this funding. It's just that that's what we know for sure. There's a huge wide spectrum of things that are possible under this funding, but because CMS hasn't approved the state's budget yet, we don't know for sure which parts of the state's plan that they proposed in their grant proposal, which anyone can read. It's available at that same QR code that is in the slides. You can read the state's whole proposal to CMS. Now, if CMS approves everything that the state advocated for, and they went hard, that includes things like investing in childcare. It includes investing in housing, and without constructing it or buying it, but who knows? But it does push for those things. And the state really, I think, did a good job of incorporating the advocacy from providers and provider groups all around the state in that proposal. So I don't mean to come off as overly negative. I just know that from our perspective with the new facility in particular, it was definitely a disappointment to see those restrictions, but it doesn't stop us from advocating to leverage this funding. And I think we are going to be successful in leveraging it because there's a lot of interest beyond us, and the state is looking actively for ways to do that.
No, if you don't mind me just adding a little bit
Go ahead,
on
Phil.
that. One thing I think it's very appropriate to do as the legislative body here locally and also our governing board is to advocate to our delegation. This is a federal, our state is, our commissioner is very supportive of some of these facilities, but they're up against the regulation as well. They can only do so much. But from a federal standpoint, advocacy for this, I think is very appropriate for approaching the delegation to speak on this, because that's where the messaging, that's where the regulation comes from on the federal side. It's in the bill, so I don't know how much there actually can be adjusted, but I strongly, urge the advocacy side at least from this body.
Okay, Member Mucci.
Yeah, thank you. Are there any borough services that fall under that RTHP program? Like I noticed there was a slide up there that talked about EMS and other stuff. Has that been looked at, that maybe there's some borough services or is this all just for healthcare or?
I know that Liz Cabrera is on it 100% and has been in communication with us as well, but I'm sure that's something the borough should speak to rather than me.
A lot of the problems that the borough has is some of the same things we've talked about tonight, which is what's the ramifications of actually getting one of these, money, and what will that cost us in the future, and us needing to explain that to an assembly when we don't have an answer to it. And the other clearly is we don't want to compete with the hospital. I talked to an AML grant writer that we have on contract. That's exactly what I told her. So I don't want to be writing anything that would take away from what the hospital's doing. And we have to know exactly what the cost is going to be down the road. And well, they can't tell you that. And I said, well, that's a problem. I can't suggest to the assembly to spend money in the future that you don't know what the money is going to be spent on. So it's not, this is I don't envy Phil and his team's work on this.
Go back to Member Mucci's question though. Would it be possible to use that part of that to upgrade? We have a very, very outdated emergency services plan, between us, the hospital, the Coast Guard, and everybody else. Would it be possible to use that as part to upgrade upgrade and bring us up to date. I think the last one we did was what, 2005 or something like that.
It's 2011, I may be wrong. But yeah.
Long time either way.
Yeah.
It,
Just, I'm just a rhetorical, but at this point, but we certainly are gonna need to do something in the future, maybe not today, but down the road.
We'll be communicating very, as much as we know. And again, I think just having good conversation back and forth on that would
Yeah.
be important. Yeah.
Okay, thank you.
I will offer specifically on EMS. There was a lot of conversation about EMS at the in-person meeting in Anchorage. That is an issue all over the state, and the Department of Health was talking about it in the breakout sessions about different goals. I would anticipate, I mean, I could be wrong, but it seemed like that's exactly the kind of area that the state would choose to focus on in an innovation demonstration grant. And I think the benefit of something like that is that the state understands that EMS all over, the Department of Health understands that EMS all over the state is highly reliant on volunteers, and that it is an incredibly important, vital, irreplaceable service. And so hopefully, and it seemed like this is the direction they're going, they would identify a demonstration project that they could absorb some of that risk while pushing out funds to those largely volunteer-led organizations and the, borough governments and village governments that support them. So I would maybe watch in the first 3 to 6 months and see if they put out a demonstration grant. And again, like Phil said, advocacy to the Department of Health on that area is valuable. But I would anticipate that's going to fall more into the innovation demonstration bucket.
Okay, thank you, Katie. Other questions from the assembly or the
I think
board?
Katie's answered my question, and I just wanted to say so the public understood that our emergency management plan, at least that involves the fire department and other public safety, references an entity that doesn't exist anymore. It was made for the city of Petersburg. We now have the borough. And I actually was going to try and help update the plan. And as I got looking into it, some of the federal regulations no longer exist that the plan references. There are lots of things that are out of date, and entities have changed and opportunities have changed. So it really does need to be updated. And we've seen up north how with the storm that happened up there, having a plan in place to be able to respond effectively if there's a community emergency is really necessary. The question that I was going to ask you though, and I think you answered it in the last thing, is the state the one that's going to evaluate the proposals, or is the federal government going to? I was concerned when you said out of Alaska entities can apply for the grants.
This is a great question. So the proposals that come in Alaska to the state of Alaska's funds, if I shared a small number of their slides, but if you follow that QR code, if you're so inclined, you can see a wide variety of slides from them. And one of them will outline that their proposed method for getting feedback on proposals. I'm not sure how this will work in practice. It seems cumbersome to me on paper, but their proposal to CMS said entities will submit grant proposals to ACF or whoever their grants administrator is. The grants administrator will evaluate them for basic fundamental compliance with the opportunity. Everything that's basically compliant will go on to the advisory council, which is representatives of AHA, ANTHC, the states, number of different entities, Alaska Primary Care Association, and that advisory council will make decisions on the proposals. They'll then go back to the grants administrator and then finally be approved by Commissioner Hedberg. To me, that seems like an extremely cumbersome proposal process, especially for open-ended LOIs, which is what they're describing. So we'll see how that actually ends up looking at. But in short, our proposals will not go to CMS. The state will have to report on our proposals to CMS. So I'm sure they will be wanting to glean a lot of data from us in reporting if we're funded. But it's honestly, that's probably where a big chunk of the money will go to, is setting up that wing of the state Department of Public Health and making sure that it's operable. The second part of your question about the outside entities, I don't mean to be alarmist about that. I think that it's pretty, standard. When there's a big amount of money, places that can be very valuable to Alaskans, companies, I should say, that can be very valuable to Alaskans may come and bring their tech proposals or their systems, their interoperability solutions, like Phil was touching on, and bring them and propose them at the state level or to individual providers in Alaska. And some of those might get funded. The state is very aware that this might be happening, and they have said several times their priority is to fund Alaskans to serve Alaskans. But I think everyone's conscious that those entities are better set up to absorb the risk, and they are already acting nationwide to make proposals at the state level and cash in on this, and not to be too cynical, but I think we're all sort of keeping an eye on that.
Thank you, Katie. Anything else, Phil, that you want to talk about there tonight?
That wraps up my my slide deck. So I'll open it up to any questions, or I know we went over, so.
Yep. Yep. Any questions from the board or the assembly? No, with that, and let me just finish, Phil, by saying that, if you need our support, we're certainly willing to support with the congressional delegation if we have something positive to contribute, with it
Appreciate that.
some way.
Yeah.
With that, Steve, do you have anything else to add? Okay, with that, thank you, everybody, for coming. And Katie, thank you for the presentation. It was excellent. And we'll bring it to a close. Thank you.
Thank you.
Thank you.